I'll be presenting a case of coronary artery occlusion after TAVR. I have no disclosures. This is a 79-year-old female with history of severe AS, COPD, and interstitial lung disease on oxygen, coronary disease with a CTO of the circ, and recent anemia requiring blood transfusion along with AFib on anticoagulation. So she's been having dyspnea with exertion and NYHA class 2 symptoms and a recent admission for heart failure exacerbation. On physical exam in clinic, her blood pressure and heart rate were okay. Her oxygen was 96% on 4 liters nasal cannula. She presented to the clinic in a wheelchair. She was kind of frail looking. She had an aortic stenosis murmur, and she was euvolemic on exam. She was 4'11", she weighed 93 kilos, and her BMI was 41. Her labs were okay, as you can see here. Her EKG showed a sinus rhythm with an incomplete right bundle. So coronary angiogram here in the top right, you can see the cranial view. There is some disease in the LAD. The left main is a little calcified, but has no obstructive disease. And then here in a caudal projection, you can see the circ CTO, and then a ramus, which we call non-obstructive. And then her right coronary showed non-obstructive disease as well. On echo, her EF was preserved, her Vmax was 4 meters per second, mean gradient was 37, and her valve area was 0.6 with mild AI. So TAVR CT, the annulus area was 386 millimeters squared, her perimeter was 71, and then the LVOT area was 378. And then her sinus was 26 by 27 by 28, and then her STJ was about 23 in diameter with some calcium, as you can see here. So her right coronary height was very reassuring at 17. The left coronary height was a little bit more borderline at 11 millimeters. Here's a 2D cine view of the aortic valve leaflet motion. So you can see here the left coronary cusp in relation to the left main. You can see kind of how it comes close to that. And then the CT also showed severe disease in her aortoiliac system, but her subclavian was more approachable with a diameter of 6.1 millimeters. So her STS score was 8.8%, and this was mostly driven by her advanced age, her frailty, and her oxygen-dependent COPD. So she was discussed at our multi-D conference, and it was felt to be a better a TAVR candidate than SAVR. And her options were either a 23 Sapien or a 26 Evolut. And our team decided to go with a 23 S3 subclavian approach, general anesthesia, and T guidance. So here on the left, you can see in the 3-cusp view, the 3 cusps are nicely aligned. And then here's our valve deployment. You can see the valve does not move much during the deployment. So it's kind of, in the intended position. And then here's our aortic root shot after, which shows no significant AI and, good filling of the coronaries. Okay, so here's our post-TAVR, the hemodynamics after, which showed no significant gradient. So closing the subclavian access, and then 20 minutes after, the patient develops severe hypotension. So you can see here her systolics are in the 60s, and she's got some EKG changes as well. So when we see this during a TAVR, we should consider a few things. So it includes pericardial effusion, either from RV pacer kind of rupture or LV wire rupture, annular rupture, coronary artery obstruction. We should consider valvular dysfunction, potentially bleeding from a vascular catastrophe, protamine reaction because she had received that, potentially, a heart block or other arrhythmia, or maybe like heavy anesthesia medication. So we asked our echocardiographer to drop the T-probe again, and you can see here that there's like a new wall motion abnormality and a reduction in the EF to the 20s. So at this point, the highest on our differential was coronary obstruction. So we engaged the left main with a an EVU4 guide. And you can see here, this is a zoomed in view. There's incomplete obstruction of the osteo left main with the native leaflet. So as soon as the blood pressure, as soon as the guide was engaged, the blood pressure improved, probably because it pushed the leaflet out of the way. And then it was wired with a Pro Water, and then we placed a 4/12 drug-eluting stent. And you can see here in a more non-selective shot that the left main is patent. And on T, there is a recovery of LV function in the cath lab. So, I asked our valve vendor to go back and reanalyze the CT to see if there were any findings that could have predicted this outcome, because, our team was not anticipating it. And there were maybe a few things. So here, this is a leaflet length that can be measured, and here, you'd see that it was 15 millimeters. So something to consider maybe in a patient who has like a borderline sinus size, along with borderline coronary height. And then here's the curved distance that was 16 millimeters. And then this is virtual valve sizing of the 23 S3 in the annulus. And this is at a position of 100 and 0 relative to the annulus, so you can see how close it comes to the left main. So the patient's LV function recovered in the cath lab. She was extubated later that day, and she was discharged after 3 days. So, takeaways from this case are that, in patients who are at slightly higher risk for coronary obstruction, such as having a borderline sinus and borderline coronary height, maybe consider measuring the leaflet length or virtual valve sizing. There's maybe a role for angiography during a balloon valvuloplasty to see how the leaflet behaves in relation to the coronary. You should consider T guidance for high-risk cases, and if you do identify these things, consider prophylactic coronary protection. Thank you.
Excellent. Are there any questions? Yes, David Wood.
So how are you going to follow her? Are you going to do any extra vigilance or anything like that? With regards to her coronary patency and things like that?
I don't think so. You mean like stress tests or something like that?
So she's just going to go on normal pathway now? Okay.
Yeah.
I guess one good question would be, would anybody have thought that this was a risk? Because I'm not so sure that any of those measurements. I mean, the height of the left coronary obviously was one, but you chose the sapien stent the sapien valve that's supposed to have better coronary access and some ability. I guess you put her on aspirin and Plavix,
right.
And you'll keep her on that. And then there's more coronary disease, so you don't think that she should have complete revascularization?
Oh.
I think that was the question of David Wood.
No, we've just had 2 come back where we did salvage stenting, and then you got proliferative ingrowth, and it was horrendous.
Oh, really?
And then so on
so
one
interesting.
and there's a small case series that some of the fellows have been collecting. So
Very
I think
interesting.
you can bail yourself out, but then
There's still to come, more to come.
Yeah, it's not normal because you've got native leaflet pin there, you've got stent coming out. So anyway,
Yeah.
just be aware that she might represent.
Any other questions, Dr. Sharma?
Yeah, no, I mean, over the years, we are done. Yeah, over the years, we are done now about 12 cases, majority of them as a prophylactic, preempting. same, less than 10 millimeter height, sinus valsalva less than 30, or combination of both, and so, I'm actually waiting that patient comes back with restenosis, and I'm hoping they never come back. So far I haven't, maybe one or two might have gone, they departed, but they had not come back with a restenosis. I think doing the PCI, that one will be a very, very tough.
If they died, they're not going to have restenosis.
Many of them are doing a tunnel, stent, long stent tunnel, although they are large, whether it should, knowing that it's very little tissue around. Remember the idea, hopefully, it may take many years to finally the tissue to grow, because it's not coming, big part of the stent is not coming in contact with much of the vessel wall. That may be the reason, but haven't seen. I don't know anybody else has seen the restenosis of this, the tunnel or ostial stents when you use the.
No, we haven't seen that. The one thing that you did notice was sort of effacement of the sinuses, and in those cases, a couple of times we've snorkeled, we've put a stent in, we've wired it, and then afterwards, if we were as close as it sort of appeared, then we'll deploy the stent after the valve is deployed, just before we leave.
The other comment is, the other comment is regarding basilica, right? In cases like that, it's painful. We don't like to do it. So I think that very soon we are testing in Brazil a device called Shortcut. That will be by CAR, the Israeli company. I think it's going to be much easier, and this is a perfect indication for this device.
Nice. All right. Fantastic.
Okay.
Thank you. Thank you so much. I'd like